I was given a task to speak about the management for the walking age children, right? So there are few. I will just go some case by case. So this is a first case. She's a 3-year girl. She's walking with this deformity. She has not been treated in past, right? So this is the way she's walking. So this is almost Demiglio, you can say a grade 3 or 4 deformity. This is a neglected club fit. So when she presented, I think it was 2004 or 2005 when we was very much on a gear of paucity. So and there was only few articles at that time available. I think only Monica and one more article from Nigeria. There were two articles only that they tried to treat these children, walking children, neglected club fit with the paucity. So I thought just we'll go ahead with the Ponsonby technique and started casting her. So this was after a few of the corrective casts. This was first, and this is I think almost fifth plaster, and then this was followed by the tenotomy, and then this was a correction. Okay, so reasonably good amount of correction which is there. So I was convinced that okay, these children they can be managed very well with the Ponsonby. And now there are so many articles even from Wadia also, from our colleagues, many of colleagues from Mumbai as well as from Delhi. They have published the articles that Ponsonby works even for the neglected clubfoot deformity. And yes, it's true that when the child is in a walking age and with say grade 1 or 2 deformity by Demiglio, or you can say by Pirani's flexible type of club fit, even though it is neglected, they can still respond to the Ponsonby well. But as you know that as Sandeep keeps on speaking in his lectures that a picture bhi baki hai dost. So in it what matters in the club foot is you have to observe these children till skeletal maturity, right? So this was the time we kept her in a good sprintage protocol, and then she was having regular follow-up also. But after 2 years now down the line, the recurrence started. So there is recurrence of the deformity. It has just started, and there is as well as if you see there is torsion in the tibia also. Subsequently, the deformities they increased, right? And this was a time then I had to think over that again. Now the parents were saying, no, no, doctor, we want now definitive treatment. So we decided first to go ahead for the left foot osteotomy, and this was the even the external rotation osteotomy of the tibia as well fibula and osteotomy for the foot. I will speak on later. And subsequently, you can see the difference between the 2 feet, the left and right one. So then subsequently, the right foot also needed the osteotomy, and then we kept her follow-up. In the follow-up, this is a 3-year follow-up she had. And subsequently, we kept her 6-monthly and 1-yearly follow-up. And then this is 5-year follow-up. And this is 12-year follow-up of this girl. So she is almost now skeletally mature. And you can see the girl, when she presented with this, we tried first with Ponsonby. We could get good correction, but then deformities recurred. And then finally, she required the osteotomy. And this is her current weight. She don't have any kind of pain, not any kind of arthritic changes. So we keep our most of the children who have undergone, this is the hopping what she's doing, and that is there. So the idea of behind presenting this case is that it's not like that every case is going to respond to particular treatment. So clubfoot is such a condition where you need to have a case-based approach where you have to decide what is going to work. Now come with the second child. This is now again the 3-year. Now this is the male child. It was a 3-year female, and he was treated with a Ponsonby, and then he had recurrence elsewhere, and then he came with this. We tried with cast, initial cast we gave, but still the deformity rigid. It was not a dynamic supination, but it is a varus and adduction of the foot which was not getting corrected. And this is a closer look. So naturally, these type of children, they may require osteotomy. So we did the osteotomy of the cuboid decancellation, and then he did well. You can do, and then additionally we had to do the tenotomy also for the tendo achilis. Additionally, as Alaric has mentioned, you can do the tibial-centered transfer also. But the idea of showing this case is that there is definitely role of osteotomy. You can either do the simple decancellation of the cuboid, or you may just you may go ahead and you can do the just distal calcaneo. You can just osteotomize like Lisch-Blau procedure, or you may take out some portion of the cuboid as well as the calcaneum, and then you can fuse it, right? That is there. Now consider the third case. Now this is a 5-year child who is walking with this. It is a neglected clubfoot again from a very poor background. So what is special about the child is, now this is a grade 3, grade 4 Dimiglio deformity. It is not a flexible variety. So the special about this child is it comes from very low socioeconomic status. He has very limited resources. He is not ready to stay at my place or at Nagpur for a long duration, because they have their farming and other issues for the parents, and they want a single stage treatment. So what to do with this type of children with grade 3 or grade 4 Dimiglio deformities and a neglected one? What to offer for that? And in Nagpur, and particularly most of those practitioners who are practicing in small cities or like taluka places, they are not, I mean, uncommon to get cases like this, or the relapse cases where the tertiary care centers do get where 2 or 3 times the soft tissue release and other surgeries has failed. So what do I offer for these kind of cases? So we came out with a novel idea where at one stop we go ahead, do the plantar fasciotomy, that is to correct the cavus, and then we do the percutaneous tendoachelis tenotomy to correct the equinescent varus, and we do the dorsal closing wedge osteotomy at the same sitting, right? So this is the pictorial presentation where we cut the tendoachelis, we do the plantar fasciotomy as well, and this is, in addition to that, we take out a dorsal close wedge where we take elliptical incision, we separate out the muscle, and then we take out the dorsal edge, which starts from right from cuboid, then all the 3 cuneiform. If it required, we sometimes we involve the navicular also, and sometimes the basis of the metatarsal as well. But mostly it's sufficient if we take out the cuboid and 3 cuneiform, and then we close the wedge and then stabilize the forefoot to the hindfoot with the help of the wires. This is how the forefoot is stabilized to the hindfoot with the help of the wires, 3K wires, and then we just close the wound and just put the drain on the third post-operative. We just from the window we pull out the drain and just send the patient home, and then directly comes back at 6 weeks where we pull out the wires, and this is the amount of correction what we have. So just the wires are pulled out and see the amount of correction which is there. We extensively worked out on this surgical procedure where we did the morphological studies, the functional evaluation, and radiological evaluation given by the International Clubfoot Study Group and the Bensal and Dimiglio et al. So, and we found that the technique is not only effective for the neglected variety, but it is as well as equally effective for the relapsed variety of the clubfoot. So this is the child which has shown you, the child who has from a very poor background, and they want one go and one stage treatment. So this is how the correction what we gave from the dorsal closing osteotomy. So this is a plantigrade foot with what he is walking, and we keep these all children under long-term follow-up. This is a 5-year follow-up of the same child. The what Alaric was talking about, the squatting, the squatting is very important position which is required by the children. So in the villages particularly, right, and actually everywhere, the squatting is one of the very important bit, and it is possible because we are not disturbing the subtalar joint. Rather, we are preserving the subtalar joint in the dorsal closing edge osteotomy, and that is why the flexibility of the tissue is also very well maintained, and the child can do the hopping and other functions. This is a squatting, and this is a dorsiflexion of the same child. So you can see that due to preservation of the subtalar joint, there is good range of mobility at the foot, and it is absolutely a penless foot with good mobility. This is an example of the recurrent deformity. Now a 9-year child who has undergone 3 times the surgeries. You can see the scars of the previous surgery, the 3 surgeries, including the posterior medial release, including the Iliazaro and the Ponseti, which were done at some other centers, and this is the way he presented. Now again, this time, this kind of fit where the parents are already fed up with our treatment, they want at a straight go type of treatment. where again this the closed edge osteotomy worked very well, and this is a 4-year follow-up of this child. After doing the osteotomy, we did the dorsal closed edge osteotomy, and this is a 10-year follow-up. Already he has achieved the skeletal maturity, and see you can he's walking very well, he's running, and he's doing all functions including the hopping also. And this is the way correction what. So the dorsal closed edge osteotomy were even for the recurrent variety of clubfoot where the previous surgeries has failed. Another example where this 8-year girl, she had a neglected type of deformity where we did the osteotomy, and this is a function. My idea of focusing here is basically the amount of function what they have. So that is very important. So so the amount of function what they have is very good, and I'm sorry. Yeah. So the advantages of this technique is basically it's a single stage procedure, and there are no much wound problems on the medial aspect because we are closing it on the lateral aspect, and so there are very less chance of neurovascular damage. There are few disadvantages. People have spoken that there can, yes, I do agree that there could be a shortening of foot, maybe 1 centimeter like that. But even if you see the original Ponseti's his own series, and they have compared that there could be shortening of even up to 2 centimeter that they have shown even the when they are managed with simply with the Ponseti technique. There's special consideration I would like to mention in this type of particularly those syndromic feet we are presenting out very late stage. What we do, we extend the same incision which we take for the tenotomy, and from the same incision we do the release of the posterior ankle capsule, and sometimes in the subtalar release also we do from the same incision. That is required for some cases like arthrodiabetic clubfoot. Like this was a child, he has presented from Nigeria, and he has 5 surgeries has already failed, and it was absolutely like a stone, patthar ke sanam jaisa. It was hulling and doing absolutely no movement. So in these type of fit, definitely you have to do the releases, and the dorsal wedge what you are going to do, if they require little wider dorsal wedge where you may have to include the navicular and sometimes the base of the metatarsus, and this is the correction what we got for the 1 feet. Then he was happy with the deformity correction. He came for the second surgery for the another foot next year, and this is the correction what we got. We extended this our techniques indication to the neurogenic foot. And neurogenic foot are not so simple because even if you do the best soft tissue balances, sometimes they recur. Many times they have this osteomyelitis and then ulcers, and so we have to the advantage of is that you can take out the ulcer from the same incision, and the bad bone we can take out. And this is a follow-up, long-term follow-up. This is 7 and almost 10 years follow-up of these cases. This is a 10-year follow-up of the we have published this paper also. So this technique works even for the neurogenic foot. And what I will mention about the triple arthrodesis, yes, when nothing works and if you are getting a very painful stiff foot with a poor function, there is definitely a role of triple arthrodesis. In summarize, you can't see that only one technique is going to work for the club foot. For the fit, what we are seeing, the Indian surgeons, what we are seeing, the walking age children, the flexible deformity, you can still try with the Ponseti extended indications. You can sometimes go for the, if the grade 2 deformity, you can give even for the Evans or Lischbach type procedures. And if the patient want a one-time treatment, the single go treatment for the grade 3, grade 4 deformity, above 5 years of the age group children, you can definitely go for the dorsal wedge osteotomy, and we have very, very long-term follow-up of these children. It suits to our all patients from the developing countries, and it works very well. And of course, for very painful foot, you don't have any other option. You have to go for the arthrodesis. Thank you for all for your attention, and sorry for the disturbance what we had.